Hi, this is Tracy Wen, and today's literature review is the association between transverse maxillary deficiency and septal deviation in adults with obstructive sleep apnea. So we have a lot of literature that looks at chronic breathing and what it does to the face, what it does for growth and development. But this article actually looked at the palate specifically. A lot of times when I lecture, I'll say the palate tells a story. So this article basically talks about this story. What exactly does a high narrow palate mean? In this study, I looked at 93 patients, predominantly male, 74% male, 73% white, mean age is 54 years old, obese with a BMI of 30 with severe OSA. So let's dive into it. So this is an older study by Guilleminault and the Stanford group in 2017. And basically it looked at, what causes a deviate? What is the possible causes of a deviated septum? And it starts with chronic mouth breathing. Now, it doesn't go into specifically what caused the chronic mouth breathing, if it was allergic rhinitis, tonsils and adenoids, but we have this behavior that's a consequence of something of chronic mouth breathing. And what does that function, that abnormal function do? So what happens with chronic mouth breathing is basically you breathe more with your mouth, less with your nose. And what we call that is eventually nasal disuse. And by not using the nose, you have an underventilated nose, increased inflammation, and increased nasal resistance. Well, you use all the faces to breathe with your mouth. Postures changes and the form changes. So here, function affects form. And what we see is the narrowing of the arches and a limited space in the nasal space because you're not using it, hence the deviated septum. So this was discussed in 2007 by Guilleminault. Now let's dive into this study and talk about the deviated septum. So this study looked at several different points, and the first point that they looked at the palatal width and height, compared that to the septal length and the nasal cavity at the premolar site and the molar site. This, like their previous study where they looked at transverse deficiency and DICE and its effect on obstruction, they did the same measurement of the palate, which is the alveolar bone. They went from premolar to premolar, molar to molar at the alveolar bone. So the reason why they did this is to take away that variable of tipped teeth. So some people tend to say, oh, I got this really broad arch for, but their teeth are tipped out and their bone is not. So that's why they use CBCT imaging and they measured it at the alveolar bone height, not at the tooth height. So what did they conclude about the study? Well, what story is a high narrow palate telling you? Okay, what's the story? Well, they found that high narrow palates were associated with septal deviations. Now, it wasn't directly linear in that if it was narrow at the molar, it was more deviated at the molar. What they actually found was that the more deviated it was at the premolar site, the more narrow it was at the premolar site, the more deviated it was at the molar site. But they totally found that a taller palatal height was associated with larger degrees of septal deviations. Now, one of the things that the study I thought was really interesting, what should we not assume? That a high narrow palate means that the patient can't breathe. So what it did was they looked at the nose questionnaire, and they found that a high narrow palate did not directly correlate to patients' complaint of symptoms of nasal obstruction. So let's recap that. When we see a high narrow palate, what's the story? The only thing that this study says that we can say with confidence is that a high narrow palate means that you have something going on with the nose. because the palate is the floor of the nose. So a high, narrow palate, you're more likely going to have some kind of structural change to the nose, hence the deviated septum. So we can say that a structural issue in the palate correlates to a structural issue in the nose. We cannot say a structural issue in the palate correlates to function. And so what this study, what they did is they looked at the nasal construction questionnaire, which is the nose. They looked at septal nose. They looked at deviated septums, nasal cartilage hypotonia. They looked at orbicular muscular hypotonia. That's basically your lip seal, nasal airway patency. And was there any reports of nasal obstruction in the last 3 months? And surprisingly, they found that there really was no correlation between the palatal height and the nose score. So we can look at this high narrow palate and we can say there's probably something going on with the nose, but we can't look at this high narrow palate and say, you probably can't breathe through your nose. Or based on the questionnaire, we can't say that you would score high on the nose questionnaire. So now let's look at the piriform rim. The piriform rim is measured at the most anterior aspect of the inferior turbinate bone, where a complete nasal rim is observed on the coronal view. So what did they find with the rim? Well, they found that there is definitely a correlation between the piriform width with the interdental widths. They did not find a correlation between the piriform width with the palatal height. And that makes sense. I mean, you see the transverse correlates to the transverse. The transverse does not correlate to the height of the palate. Another thing that you cannot say just by looking at the palate is you can't say just by looking at the palate, you have OSA and you probably have a high AHI score. So in this study, they found that there was no correlation between high narrow palates and AHI and OSA. So in conclusion, what kind of story does the palate say? We can confidently say that a high narrow palate does influence the nose. They found that the higher the palatal arch at the premolar site, it definitely influenced the nasal septum at the molar site. And again, we cannot say a high narrow palate influence nasal obstruction based on the symptoms questionnaire. Notables that this is the first study that measures septal length as a variable and compared it to the nasal cavity height when evaluating the impact of maxillary development of septal deviations. A couple of things I threw in this article, because this is an article that I actually post in the literature review module 3 in ASAP. But basically, the consensus is children with deviated septums, we don't operate on them until we wait for them to stop growing, or unless they have a severe OSA. But even then, I think most ENTs typically like to wait till they stop growing. Now, we just said that the palatal height is correlated to the septal deviation. So one would think that if we influence the palate, we can influence the nose in a growing child. And in this study, it looked at effects of rapid palatal expansion on the nasal septum, 2019. The mean age were children between the ages of 6 to 12 years old. And they found that when we expanded them, what happened to the nose? Well, we saw a positive change in the nasal septal asymmetry. We saw an increase in the nasal cavity volume due to the downward and forward movement and a lateral incline of the nasal cavity. We saw a reduction in nasal resistance, because that makes sense. As you increase the nasal volume, you're going to reduce the nasal resistance. We saw improved breathing and increased length of the septum. Now, they saw a positive effect on the nasal septum. I did not say we could correct the septal deviation. I personally have not corrected any septal deviations with expansion, but I have seen the deviation improved. But with that being said, that is also a risk factor that when you expand, that the septal deviation may get worse. So because you are expanding like the entire complex. More in this study, as we found a reduction of the septal deviation found in both the middle and lower tract, increased nasal septum in the length in the upper and lower tracts, increased piriform width, increased lateral walls, downward movement of the nasal floor. So I think in our last study where I showed the risk of a septal deviation, I think to combat that would be to look at ways that we can treat children with septal deviations. And we could see this in CBCT imaging. So the question is, when you're doing your decision tree on what to do, when you see a septal deviation, to my knowledge, this is the only study, well, this is one of the other many studies that looked at expansion, rapid palatal expansion's effect on the septal deviation in a positive effect. So now we're going to look at, nasal surgeries and OSA, and many studies will say that nasal surgeries alone is not a standalone practice for treatment of obstructive sleep apnea. It doesn't reduce the numbers. And I always tell my patients, it's like, what we find with nasal surgeries is it improves the quality of life. You feel better and you breathe better. But if it's a numbers game, nasal surgery alone is not going to do the trick. This is another study, and this is with the Stanford group. And basically what they found was that patients that were still resistant or little improvement from nasal surgeries, they all had high narrow arch palates. So interesting enough that in my team, the question is always who goes first. In children and adults. So in children, the answer for me is pretty easy. Once the tonsils and adenoids are taken care of, the next line of therapy would be orthodontic intervention, because nasal surgeries generally are reserved until you get older. Now, in adults, I think nasal surgeries should also wait after correcting the transverse with a non-surgical expansion or even surgical expansion. And the reason being is because with non-surgical expansion with the mini pins, you're still moving the entire complex. So the challenge is, if there's been any kind of nasal surgeries or pins in the nose, anything, you're going to be opening up old wounds and things are going to change. So we actually like to do a nasal evaluation after the expansion. I want to end it with, we all know the benefits of expansion in children. And we have tons of literature to show that we are improving nasal function. And I just showed you how we can restore nasal structure. As we expand the arch, we have studies to show that the head posture uprights and the tongue goes up and forward. As everything goes up and forward, we displace the mandible, and hopefully we can get the mandible to auto rotate forward. And by bringing both jaws forward, we in essence have done double jaw advancement in children. And by bringing both jaws forward, we're gonna open up the airway 360 degrees. And by doing that, we can reduce the AHI, RDI, oxygen saturation, improve overall sleep quality and quality of life. Thank you so much.